All right, welcome to the second lecture on chapter 26 for the female reproductive system. For this lecture, we'll be looking at the physiology of the female reproductive system. So as we discussed earlier, our gamete is made in the ovaries, and the process by which the gamete is made, our oocyte, is oogenesis. And so in females, unlike males where we talked about spermatogenesis, oogenesis actually starts before birth. And so our female stem cells is called the oogonium, and it is a 2N cell. The oogonia actually begins meiosis in the 3rd to 7th month of fetal development. So it undergoes its first round of division and becomes a primary oocyte within that 3rd to 7th month of fetal development. At this point, when it is a primary oocyte, it is arrested in prophase 1. Recall that meiosis is 2 rounds of division, meiosis 1, meiosis 2. In meiosis 1, we divide our homologs, so we are truly haploid at the end of meiosis 1 because we no longer have a copy of each homolog. And then in meiosis 2 is where we divide our sister chromatids. Also recall in meiosis 1 or in meiosis 1 that we have crossing over in prophase 1, so that's where we get our genetic variability, and then the random alignment and assortment of our homologs in metaphase 1 is where we introduce even more genetic diversity. So here at the time of birth, all of a female's oocytes are arrested in prophase 1 as a primary oocyte. This area over here is going to show us the development of the follicle along with the development of the ovum. And so when we are arrested in prophase 1 and when we're born, all of our follicles are sitting in this primordial follicle phase. And the way you will see as a primordial follicle is it's surrounded by a squamous layer of cells. These are going to be your follicular cells. After birth and until puberty, nothing happens with our ovums. It sits in that primary oocyte phase, but we do get some follicular development between childbirth and puberty. And so we get stratification of the granulosal cells here, where we become a primary follicle. And then when we start seeing little fluid pockets, follicular fluid pockets appearing, we become a secondary follicle. And so we start to develop our follicles, but we don't actually have development of the oocyte until we hit puberty. Once we hit puberty, we have the development of at least one ovum each month, sometimes more. And so when we hit puberty each month, some of those primary oocytes that are arrested in prophase 1 will continue through meiosis. At the end of meiosis 1, they release a polar body and a secondary oocyte. That secondary oocyte enters into meiosis 2, where it continues into metaphase 2, and it stops in metaphase 2 and stays in metaphase 2 unless a sperm fertilizes the oocyte. If it is never fertilized and it is released during your menses, then it will just be released in metaphase 2 and never finish out meiosis. But if it is fertilized, it will finish out meiosis 2, release a secondary polar body with the excess DNA in it. So remember, we've got to get rid of part of our DNA. And then the ovum, the fertilized ovum, will continue to develop into a blastocyst, which we'll look at in chapter 27. So follicular development as we went along. So remembered we started developing some small fluid-filled pockets, but when we are cycling each month, when we are making our secondary oocyte, those fluid-filled pockets come together and make a large antrum. And so this really should be pointing over here into this fluid-filled area. And that large fluid-filled cavity is our antrum. And housed in all those granulosal cells is our secondary oocyte. And this is a vesicular follicle. You may also hear it referred to as a Graafian follicle. Once we've rested in metaphase 2 and we get a surge of LH and FSH, if you recall those from our endocrine chapter, luteinizing hormone. Actually, it's a surge of luteinizing hormone. Then we get ovulation. And so the secondary oocyte is ovulated with a layer of those granulosal cells still surrounding it, and it degrades into a corpus luteum. And we will see in just a few minutes how when the follicle is developing, our granulosal cells are making estrogen. Once ovulation occurs, still makes estrogen, but now it starts to make progesterone also. Estrogen is going to drop, and progesterone is really going to take off once the corpus luteum forms. And that progesterone from the corpus luteum is what will maintain our pregnancy for the first 3 months. And so here is the entire stages of both the development of the ovum and the development of the follicle. So how does spermatogenesis and oogenesis compare? So spermatogenesis can produce millions of sperm every day, whereas oogenesis just produces one viable secondary oocyte approximately once every month. And so that's one of the big key differences. Time of onset, both of them. So spermatogenesis, none of it begins before puberty. And if you remember, we saw that we begin the development of the ovum before birth. It arrests in prophase 1, and all of our ovum are already in prophase 1 when we are born. Then what happens at puberty? Spermatogenesis begins at puberty and continuously produces sperm cells throughout the male's life. Whereas with females, oogenesis, meiosis resumes. One primary oocyte stimulated to mature, and sometimes it's more, but at least one is stimulated to mature to a secondary oocyte each month and be ovulated. And this usually only lasts until a woman gets into her 40s or 50s, and then menopause and hormones go down and menses stops. Spermatogenesis produces millions of small motile sperm, whereas oogenesis produces just the one large secondary oocyte arrested in metaphase 2 each month. Meiosis, each round of spermatogenesis gives you 4 haploid spermatids, whereas in oogenesis you just get 1 haploid ovum and 2 haploid polar bodies that generally degenerate within the female's reproductive tract. Process ends. Spermatogenesis, as I mentioned, males can do it until death, whereas females tend to cease the development of ovum during menopause between the ages of 45 and 55. Duration of meiosis, continuous throughout life for males, pauses twice in females, once at prophase 1, prenatal, and then again starts at puberty, arrest at metaphase 2 when ovulated, and will only finish out meiosis 2 if the ovum is fertilized. And so here we can see the photomicrographs of our different follicles. So primordial just has that squamous layer of cells surrounding it. Primary, we start getting the cuboidal cells around it, and they start stratifying. Secondary follicle, we start having these little fluid-filled pockets of follicular fluid. And then our fascicular or Graafian follicle, we have this large antrum filled with fluid and these dense layer of granulosal cells surrounding the secondary oocyte. These outer cells are our thecal cells in our mature follicle. Then once ovulation takes place, those granulosal cells that are left on the ovary revert to being a corpus luteum. So this is the remnant of our ruptured follicle. They start secreting progesterone and some estrogens. So all along here, during the development of the follicle is making some estrogens. And then after ovulation, when it becomes a corpus luteum, makes both estrogens and progesterones. If fertilization doesn't take place, if the embryo does not start secreting HCG, human chorionic gonadotropin hormone, to maintain the corpus luteum, then that corpus luteum will degrade into a corpus albigenus and hormone secretion will cease. So again, we have to have a viable embryo implanted into the uterine wall, making HCG to maintain the corpus luteum, to maintain progesterone production. Progesterone maintains the embryo, and then the embryo maintains the corpus luteum, and they have this mechanism for the first 3 months until the placenta takes over and starts making the progesterone. So what is our HPG axis? So the HPG axis stands for the hypothalamic pituitary gonadal axis. And if you recall back to the endocrine chapter, that's how we set up our first tier, second tier, third tier control. And so our hypothalamus makes gonadotropin releasing hormone. The gonadotropin releasing hormone stimulates the anterior pituitary to make luteinizing hormone and follicle stimulating hormone. The LH and FSH act on the follicles in the ovary. LH stimulates the ovaries to secrete androgens, and then the ovaries convert androgens to estrogens and secrete estrogens and inhibin in response to FSH. Those estrogens further act on the dominant follicle to mature it to a vesicular follicle. This new vesicular follicle now makes large amounts of estrogens. And so these large amounts of estrogens feed back to the anterior pituitary and trigger an LH surge from the anterior pituitary. And it is that LH surge that causes ovulation. Then once the estrogens get to extremely high levels, they can go back and inhibit GnRH secretion. Inhibin also helps to decrease FSH secretion. The estrogens that are made by the ovaries stimulate the redevelopment of the endometrial layer. Remember when we looked at the uterus, we saw that the innermost layer was the endometrial layer. So this is the endometrium surrounding the entire inside of the uterus. The endometrium itself is made up of two layers, the stratum functionalis and the stratum basialis. And so the stratum basialis remains throughout the uterine cycle and is never sloughed off. So this is what the uterine lining is always rebuilt from. So day 1 of our menstrual cycle, or day 1 of our uterine cycle, is our menstrual phase. It lasts for 5 to 6 days. This is when we're sloughing off that stratum functionalis if there has been no pregnancy. And so this is our monthly cycle. After that, then we have the LH starting to rebuild the follicles, And so the LH stimulates the follicles and development, and the FSH converts that into estrogens, and the estrogens start rebuilding the uterine lining. And the time period from about 5.5 to day 14, which is where we do ovulation, is our proliferative phase. This is where we are proliferating, rebuilding the uterine lining, getting ready for the implantation of that embryo. With the LH surge, so remember those really high levels of estrogen that we just saw back on the HPG axis? That real high surge of LH stimulates ovulation. Then when we have ovulation, that granulosal cells now convert into the corpus luteum. The corpus luteum starts making progesterone along with estrogens, and those together continue to build the uterine lining. This is during the secretory phase. We get these endometrial glands. We get lots of vascularization. And in those glands, we start secreting what we call uterine milk. Usually takes about 7 days from the time of ovulation. The egg is viable for 24 to 48 hours. So the sperm have to be out there in that ampulla. If you recall, I pointed out where fertilization tends to take place in the ampulla of the uterine tube. And then it is fertilized out there, and it takes another 5 to 7 days to traverse back into the uterine cavity and implant in this lush secretory phase of our uterine lining, the development of the uterine lining. And once it does that, it will start secreting HCG and maintain the progesterone. If that happens, then we maintain this uterine lining. But if pregnancy does not occur and there's no HCG to maintain that corpus luteum, it degrades to corpus albuginus, and menses starts again, and we start the cycle over. So there are 3 phases to our uterine cycle: the menstrual phase, the proliferative phase, and the secretory phase. And those hormones that we've been talking about, so our 2 anterior pituitary hormones are our LH and FSH. During the menstrual phase, we can see that the LH and the FSH are starting to rise, and they help with the development of the follicle. And then as those estrogens rise, we get this LH and FSH surge, but it's the LH surge is predominantly responsible that triggers ovulation. And that's at day 14. And remember, right now, we just finished the proliferative phase of our uterine development. And you can see how the follicles are developing. As the follicles develop, estrogens increase. And then we get ovulation, degradation into the corpus luteum. Once that corpus luteum starts forming, we get rising levels of progesterone, still have estrogens, but it starts making more and more progesterone as we go further into that secretory phase of the uterine lining. And then if pregnancy is not established, corpus luteum degrades, progesterone drops off, and we start all over again over here. Remember, these are ovarian hormones. Ovarian hormones are estrogen and progesterone. Our anterior pituitary hormones are LH and FSH, luteinizing hormone and follicle stimulating hormone. Remember to spell everything out. I don't want abbreviations. And so here we can see it all tied together with our ovarian cycle, with the anti-pituitary hormones, the ovarian hormones, and then the development of the uterine lining. Here is a list of all of our major reproductive hormones in males and females and the responses that take place. So males are on top, females on the bottom. I also have them in larger tables. Here's the males, and then females and females. At puberty, for most girls, puberty begins at 9 to 11 years of age. Progesterone increases from the ovaries. That increase in progesterone is what starts the development of the uterine lining. And so At puberty, that hypothalamus becomes less sensitive to the low levels of estrogen because remember, estrogen feeds back and shuts off the hypothalamus because it becomes less sensitive. Now the hypothalamus will release more GnRH. That GnRH elevates LH and FSH, and we start the cycling. We get the estrogens. The more estrogens that we get, we also get our secondary sex characteristics. Those secondary sex characteristics, first signs of that are our budding breast, followed by appearance of pubic and axillary hair, increased adipose tissue in our hips, thighs, and breasts. So it's not our fault. Puberty makes us get larger hips, thighs, and breasts. And then individuals' height increases, hips widen. We start our cycling, our first menarche, and it is the first episode of menstrual bleeding. Usually occurs approximately 2 years after the onset of puberty. But if you are underweight and have very little body fat, like a lot of athletes have, and they're not underweight because they have muscle mass, but if you have less than 15 to 7% body fat, you actually will not start menstruating, because if you recall, those are steroidal hormones, and the steroidal hormones are made from the fats. They're a lipid-based. And so leptin, secreted by the adipocytes, stimulates gonadotropin secretion. And if that leptin drops because you don't have any body fat, then that low body fat percentage will cause the HPG axis to decline. At the end of our cycling, we have menopause. So that's where we stop menstruating for at least a year. Your number of primary follicles left cannot respond to LH and FSH. The remaining follicles are less responsive to gonadotropins, so less estrogens and progesterones. And then ovulation does not occur. And when ovulation does not occur, then we stop cycling. Lots of side effects from menopause. So those reduced levels of estrogens and progesterones reduce our female secondary sex characteristics. Breasts shrink, pubic and axillary hair may thin, bone density decreases. You get vasomotor signs such as hot flashes. And then here's a diagram depicting a lot of causes or symptoms of menopause: headaches, weight gain, hot flashes, vaginal dryness, pain during intercourse. So lots of things happen when we hit menopause. And remember, men can have andropausa, but usually it's not quite as severe as a female's menopause. Lots of methods of birth control can be used: condoms, diaphragms, spermicides, oral contraceptives, vaginal rings, skin patches. And if you look in your text, you can see a table that talks about how well they are at preventing pregnancies. And with any form of birth control, it's the active use and the consistent use of it that will prevent pregnancies the most. But abstinence will be the only thing that's guaranteed to prevent pregnancies. So that's all I have on female physiology. If you have any questions, be sure to let me know. Have a great day.